We are going to start the fourth session. In this session, we wanted to bring back our speakers and to get them to talk about questions and topics that we felt were important in a panel fashion. For this session, our moderator will be Professor Eugenio Mercuri. And so, Eugenio, the floor is yours.
Xenia, I think in this final question, we will try to address a few questions which are really important. The first one is, what are the unmet needs regarding nutritional care in SMA, and how can we as a community start to address some of these needs? And the second one is, has standard of care evolved in terms of nutritional care and intervention since disease-modifying therapies have become available? And if so, how has it changed? So in order to do this, I have prepared a few slides trying to see what we have learned from our experience with disease-modifying drugs. Before these therapies became available, the concept was that all people with type 1 SMA, regardless of, before treatment, experience deterioration of bulbar function, regardless of standard of care treatment, experience deterioration of bulbar function. That's what we thought, and that was why we were also keen on intervening as early as possible, because we knew that once started, there was always the deterioration of bulbar function, as we have seen this morning, also looking at the longitudinal ORSAT data. All the studies, however, using the clinical trials, but also the real-world data, strongly suggest that if patients are treated, especially if they're treated very early, there is a high possibility of maintaining bulbar function over the duration of the study. And the follow-up studies, and the follow-up long-term extension of the studies have confirmed this trend. And the recent follow-up studies confirm the durability of this effect in most people with SMA. And one of the questions is always to think, is this true? Does this hold true when we go from a selected population that was selected with very little bulbar function problems? What happens if we select, if we go into the real world when there are children and infants who already have some problems? So these disease-modifying therapies are now commercially available, and they have been used across a much larger spectrum of age and severity than the children assessed in the clinical trials. And some of them, if not many of them, already have some signs of bulbar dysfunction, and these were initially excluded from the clinical trial. So what happens to these children? And this is a graph showing our experience with some children who were treated in the first 6 months, especially if they were treated very early. And you can see that the idea that all the children with type 1 SMA will experience deterioration of bulbar function is not true any longer, especially if the children are treated very early. So if treated early or in the absence of clinical sign of abnormal swallowing, people with SMA may not develop signs of bulbar dysfunction. And you can see in this graph that the follow-up of some of the children is over 3 years, and there is no obvious signs that the deterioration may start at a later stage. So the first concept that we should always expect deterioration of bulbar function has now changed significantly after the therapies. Another concept is that once we observe some swallowing problems, these are always progressive. And when we insert gastrostomy, there is no going back. After we put gastrostomy, children will not improve over time. This is something that we saw consistently in all the untreated patients before the advent of the new therapies. And with the advent of the new therapies, we have really a lot of changes because you see in these children the dot is the circle are when gastrostomy was inserted, and these were children who were doing relatively well, and then they had an acute event, and during the acute event they had an aspiration of pneumonia. And in the past, when there was one episode of aspiration of pneumonia, we always inserted a gastrostomy because we knew that there was no going back from the gastrostomy, because the children were not improving. These are two examples, but I can show you many others where a gastrostomy was inserted, and these were early days when we started with the new disease-modifying therapies, and we were still not fully aware of what would be the follow-up of the children. The children had the gastrostomy, but they also underwent a program of rehabilitation. And you can see that in both cases, which are just the two extremes of the spectrum, there was in both an improvement. And in one of the two, actually, the one with the blue line, we ended up closing the gastrostomy. So the individual trajectory show that rehabilitation, even in children who had a gastrostomy following an acute event, can show that there is regaining some of the functional activities. Now, this day would probably not be so keen on performing a gastrostomy as we did in these children at the time when we were starting using these therapies. But even if this is done, rehabilitation can make a difference, and we have observed going back to function that was never observed before the advent of the therapies. Other concept is in children who had a gastrostomy before they were treated. In the past, once the gastrostomy was inserted, there was no attempt to have a systematic rehabilitation approach, because these children were felt that they could not improve over time. And these are children who had a gastrostomy before they started treatment, and they are still on gastrostomy, but you can see that in many of them, and again, these are just a few cases that we collected at the beginning, but these have been confirmed by several other cases, you can see that in all there was an improvement, and these children are now able to partially be fed by mouth. And this has a lot of importance also, as this morning has been stressed by family representative, how important is also psychologically and socially and so on. So in the past, rehabilitation was not used. Now the indication is that rehabilitation for people who require tube feeding before the time of treatment can be very helpful. And there is an rapidly increasing number of people with tube feeding that restarted to eat by mouth. And of course, this is to be done under supervision. We cannot just allow the family to try if they can eat by mouth or not. This is to be done as part of the rehabilitation program under supervision. So many things have changed. these concepts that we are discussing today would have never been discussed in the past, because it was always felt that there was always a decline, and there was a progressive deterioration with no possibility to go back. So the conclusion of these few slides, which will be helpful for discussion, is that we have to be more open and more flexible on the approach that we have to these children. Using the ORSAT, we were able to have some scores which help us to make some graphs, but irrespective of the ORSAT, what is true is that the degree of functional impairment at the time of treatment initiation can help us to predict the progression of swallowing abilities. Children who are doing well will probably continue to do well, or the great majority will continue to do well if treated early. But the need is really to change the approach to the management of bulbar dysfunction, even in the children who already had a gastrostomy, or in the ones who may need a gastrostomy that often happens because of an acute event. This is where we really need to be more systematic in the assessments and in the rehabilitation of the bulbar dysfunction. And this will help us also to improve many aspects that in the past were not even tried to be improved. And I think these are all crucial points that will be part of our discussion. So I think these slides have already opened the discussion that standards of care have evolved in terms of nutritional care and intervention. We now are much more keen on long-term monitoring and providing also intervention with rehabilitation. But I open the discussion with the rest of the panel and for questions and intervention from home.
Yeah, if I can add, I definitely agree with Eugenio about the fact that these aspects of preserving function is attracting more and more attention, because of course in the past, especially for the severe forms of the disease, there was no somehow the idea to maintain. It was mainly aimed at, of course, protecting airways or to put a tube in place because it was not considered safe. And now also, at least in my experience, I see that the speech and language therapists are much more keen to somehow maintain, the joy to provide some oral feeding to the patients, because this is also something that is helpful to preserve function, but also has, as we said, some psychological implication for the children, for the families. And we are also seeing, the possibility to regain some mild tasting or some mild abilities orally, also in the patients that were already, tube fed. And so definitely something that is changing in our clinical practice, and we should try to look at more properly. Another aspect is also probably to have to build up the evidence and the experience when there is some progression of the bulbar function, if there is any other approach in terms of treatments that we can take on. But this, of course, is something that we need to collect the evidence about. I don't know if someone else has got any other comment.
One point I would like to ask the rest of the panel is, in the past, in some countries like in the States, gastrostomy was performed nearly prophylactically in type 1 SMA together with fundoplication with Nissen. Of course, this is not done these days, but also our approach to even to a single episode of aspiration or of coughing was very aggressive, because we knew that once this problem started, they would go worse with time, and often very rapidly. So I think we, at the beginning of when the new therapies became available, we have still kept for some time this aggressive approach of treating with the tube feeding and many of the patients who may not be treating now. I was wondering whether the others from the panel want to comment on this, whether this approach has changed in their practice as well.
I could speak to that a bit. I would agree with that completely. It's changed completely. I would say that we now treat our patients with SMA from a swallowing standpoint much more like we treat most other dysphagia patients. It used to be SMA was sort of this really cautious group we worked with. So I think in talking about how that's treated, it's a really important thing to go back and say what we don't know, which is we have never done instrumental assessments from a pediatric standpoint on healthy infants. That's never been done. So for example, if you get swallow study results back, somebody may say, oh, they had laryngeal penetration, this is abnormal. We don't know if that's abnormal. Actually, no one's ever done a study to demonstrate that. So I think I bring that up because what we're finding in our patients with SMA, when we do swallow studies within the first week to 2 weeks of life, they might be a 2-copy, a 3-copy, we have all sorts. But what we're finding is that those patients, I think every single one so far has exhibited laryngeal penetration. And we've seen that in other populations like preemies as well that are completely functional. None of these children are having functional impairments in feeding. They're full oral intake, stable respiratory health. So I bring that up because that may be a very normal finding. We just are now seeing it in patients because we're doing these routine assessments and looking at them. So I think approach to what we've been seeing now, at least at our site, is we see these results. Maybe they have penetration, maybe they have aspiration, but they're not having any functional impairments. We don't treat that. We closely monitor them, and that's where the clinical following up virtual visits are great to see if they start to have any issues, and then we know we can intervene. I've seen some cases where they continue with those functionally, they're completely fine and their physiologic assessments remain the same. And so we don't do anything. And then I have other children who they start to have frequent respiratory infections or things like that. Nothing that's admitting them to the hospital like it used to be. And then we provide a treatment such as thickened liquids, and those deficits resolve. So I think that's really where we're not quite sure what's normal, what should we be expecting, but where that close follow-up and looking at whole systemic health is so important.
Yeah, I think this is a huge change, and I was wondering how diffuse this is, because I know that in care, in centers where there is a lot of care on these aspects, there has been the change I was mentioning that you have confirmed on a larger scale. I was wondering whether the other panelists want to address this point, or someone from the audience have anything to say about this point, because I think this is really an extremely important point that will avoid a lot of early gastrostomy that are not needed.
I can maybe add a perspective to that. I think what we see is there is really a lot of variability, that there are huge differences in the care standards that are applied. And I think I would also like to balance maybe what has been said so far. I would, as a parent, never prophylactically advise another parent to let their child get a feeding tube. But I think it's also very important that we do not scare off parents, and that we are that parents are well educated and well aware of what the symptoms are of aspiration. If I look back to how when my son was a small baby and he just started treatment, I think at that time we were very scared that my son would need a feeding tube, and we were sometimes perhaps a bit in denial that actually a feeding tube could have helped him. Even if perhaps a few months later he would not have needed it anymore, I think in the first months a feeding tube definitely could have supported him. So I think indeed on the one hand we should not give it prophylactically, but we should also not be, or not we, but you guys should also not be too conservative. Of course, they are getting stronger in these first few months, years. They are regaining abilities, but it's also important to keep them safe. Again, based on our own experience, we have had a few admissions in the hospital with aspiration pneumonia, and this is very scary for the child, but also for the parents. So I think finding a good balance there is very important.
Absolutely, you are absolutely right. And when I was referring to prophylactic, I was referring to the past before the disease-modifying therapies. I don't think anyone is suggesting prophylactic at the moment.
May I also jump in with a comment, Eugenio?
Sorry?
May I jump in with another comment?
Sure, of course.
So I think that what you pointed out of evaluating the possible differences in the care now, that you mentioned at least 3 times in your comment, was that it needs to be monitored and done in a safe context. So I think that, again, as we were discussing in the previous talks when we were together again here, there is still a need to get more data and to be sure as to when we can actually make this change and how to measure it. So, and the other point that you also mentioned, and it came up before, was fatigue, again, because some of the kids may not maybe have a structured swallowing difficulty to begin with, but they get easily tired, and that's when they get the aspiration. So again, this other totally different or tied issue of fatigue, I think plays an important role in the beginning of the problems with swallowing and mastication. So we're not there yet quite. So, but it's important things that we need to work on.
And sorry, this just actually reminded me of another point that was also discussed today, fasting. I think how was it your study where we saw that for some children fasting is very difficult very dangerous.
Yes.
Without a feeding tube, it is really difficult in normal daily life to feed your child every 4 hours. This is sometimes just impossible. You also want them to sleep properly at night. So also in these cases, a feeding tube can still support. It doesn't have to be, as we also showed in our data, it doesn't have to be the only way.
And it's not permanent.
And it's not permanent, indeed.
Yes, if I may add, well, I think this connects to another point we also should address in future. What about recommendations for nutrition during specific situations? Fasting is one example, but the same is for operative procedures, possibly during, before, or directly after surgery, or during infections, because patients with low muscle volume tend to be hypoglycemic and such complications that typically not occur if you have a normal muscle volume. So I think also the nutritional recommendations for specific situations should be there.
I think this kind of represents the unknown as we go into the changing landscape for disease-modifying treatments, not only in nutrition, but I think for us, we change from a model of expecting and prophylactically introducing something like a G-tube to being more a team-based approach. For example, monitoring closely fatigue in regards to how long a baby can suck, how much food intake they're taking, their growth chart, as well as their motor milestones. And as a team, we discuss that together and see if there's any deficits or concerns in which we need to be more aggressive in our method of screening or assessment.
Thank you, Tina. I think all these points are very relevant, and we have moved from swallowing to again to nutrition, which was what we have also discussed earlier today. Now, one of the issues is that there are still unmet needs, but these needs have changed following the advent of the therapies. I think one of the concern in providing some help, or even for the community to proceed to address some of these needs, the first thing is to start trying to look at these points in a structured way, because very often we talk about SMA, like all the SMA people were the same, and now we also have further subgroups of the ones who were treated, of the one who were treated early, or the one who were treated late, and so on. So I would like to think of proposing that maybe we should start with a structure that would allow to give to understand, first to identify which are the unmet needs for each category, because what Tim sees in his clinic, which is mainly adults, is very different from what I see in my type 1 clinic, and so on. So one suggestion could be to start addressing the unmet needs by the different subgroups rather than lumping all together. So I go back to Tim. If we were to address adults, what do you think are the unmet needs for your population, and what are the ways to address these needs?
Yes, I think there is much work to do, especially with the adults. And the first thing is that the adults are not a group of its own. There are, like in the pediatric population, there are many different phenotypes and a broad heterogeneous, more heterogeneous forms of SMA during adulthood. So I think it's first important to focus on awareness that also patients that seems to be more or less affected should be asked, should be analyzed for bulbary dysfunction, for swallowing problems, for recommendations for nutrition. So we had the problem that we don't that we know less about the disease caused during adulthood when we look at motor function of extremities, but the same or more important is it now if with the experience we have so far with the motor outcome, especially of the treatment during adulthood, but we have neglected a little bit the bulbary dysfunction. So I think we have to do more of our homework. We have to look with what patients typically develop even in late adulthood, swallowing problems, and how can we assess that? And I don't think that there is a one-size-fits-all approach, not the one questionnaire or the one examination with which you get the information you need. I think we have to focus more on the different phenotypes, especially when you think about adult SMA type 3 patients or formerly known type 3 patients. There is so much heterogeneity if you look at patients that lose their ability of walk well if they are 6 or if they are 20 or 30 years. So I think we have a very close look on the disease cause and on the different phenotypes, and really examine who develops or who is at risk to develop swallowing or bulbary dysfunctional problems.
And I know that in adults, standards of care, of course, were observed, but many adults did not attend regularly the clinics, as we know that many came back because of the new drugs, and also it was a bit more difficult to have a structured assessment as we do more routinely in pediatric age. Do you think that the advent of the therapies has changed what you do in clinical practice, or because these adult patients are overall doing also maybe better, there has been no change in what you do in clinical practice?
Yes, I think that the situation has changed. We don't know how many untreated patients are out there, because I think that especially the adults, if they don't want to be treated, if they are possibly not aware of the current treatment options, they don't come very regular to the treatment centers. So we mainly focus on the patients who are treated or who wants to be treated, and we have now much experience with the treatment, especially with the motor outcomes. So I think now is the time to focus on bulbary dysfunction.
I would like to focus on nutrition first, then we will go to swallow. Do you think for nutrition people are more aware of the increased weight in some adults, or
Yes. Yes, I think we should focus, because patients ask for that. They ask if there is a specific diet, if they go on treatment A or go on treatment B, if they are untreated. And currently, I don't have a good answer on that. It is more gut feelings, but no structured approach. But I think there is a need for that, and now is possibly the time for that, because with the motor outcomes, we know what we are doing. With nutritional stages or something like that, we first have to develop an idea how to approach that best, and then do it in a structured way within the clinics. So I think the situation hasn't changed currently, but I think it should change within the next years.
Thank you. And I think we have discussed today in several parts that we always pay more attention to the infants, and I'm not sure we should still call them type 1, or anyway to the infant onset SMA, and we have discussed a lot about nutrition, the hypoglycemia, and so on. There is still a group which haven't targeted, which are the sitters, the type 2 and the non-3 sitters. And today we heard of the variability of findings, especially with weight, and with some cultural differences, as Giovanni was stating. I also have the same experience that in Italy we have less undernourished children than in other countries, and the importance of spending enough time and so on, which is not only that. Does someone wants to recap a bit on what we have discussed today, or bring other issues on it now that we have the new disease-modifying therapies, do we still have the unmet need? Do we think the children are doing better in terms of weight compared to the past when they were untreated? Anyone wants to comment on that? Giovanni, others? Tina? Or?
I can comment on this because I believe you mentioned the unmet needs for adults, and when I talk to other adults with SMA, this is the big question is how to get more energy. So it's not only the motoric, the functions that are needed to be addressed, but also in terms of how to get more energy and to have the right nutrition and a good balance in your diet and your exercise. And for adults, treatments are not available in many countries, so it's even more important for us to try to beat the fatigue in other ways because we are not allowed to have medical treatment. So I believe that this is an area that there are many questions, and it's a big area in what kind of diet, how many calories, supplements, exercise, the level of exercise, type of exercise, and so on. And also SMA have many phases, so it's different for different people in what would be the best way, I believe.
No, you're absolutely right.
To tag on a little bit with what Sarah was saying, in regards to nutrition and exercise, from even transitional pediatrics or teenagers all the way to adults, there's differing needs. And what I found is that there are a lot of patients are asking more questions as they're doing their own kind of combination therapies of not only the disease modifying treatment, but exercise on top of the changing physical activity. And I think for patients with type 2 or sitters more, they may have increased activity, but how does that relate to someone who's more transitioning, and as they gain some motor skills or more endurance, they may be more active. And we don't know how to individualize that plan to have a nutrition plan that coincides with their changing activity level. And I think the difficulty is in the world of measuring exercise and physical activity, working alongside a dietitian in order to better inform patients of that. And then so that whenever patients, I think, Sarah, you made a point that really stood out to me, that this happens to our patients too, where they're underweight, then all of a sudden they're overweight. Where was that tipping point, and what are the variables that are unknown that maybe we can address to help not have that going from underweight to overweight? Because we have some patients who are on treatment and doing exercise and trying and eating more than they ever have, and yet still not being able to gain weight.
The last question for this part, and then you can move to the swallowing, is to Dr. Gousset, to Nicole, and to say, how can we, these things we are learning these things, and I think among tertiary centers and experts, we have a sort of a few suggestions on diets and exercise and so on. How can we make sure that this information is spread also outside the tertiary care centers? Because many children, many people with SMA will not necessarily attend tertiary care centers. Is there a plan for implementing some suggestions or promoting awareness of this?
I can start. I think for this we all really need to work together. Patient organizations, I think, can play a huge role. Or should play a big role here. I think it's very important that we do not only reach the clinicians, the therapists that are very involved with the clinical trials and so on, but that we really reach these healthcare workers who are really on the ground working with the patients in their everyday lives. So I think here I will take a responsibility, not personally, but for my organization and our national patient organizations. But I think it's also very important that in all of the research that you guys are doing, that you involve us in some way or another, that we do this together, that we work together on the needs of the patients, and that we also together disseminate all of this information. I think only in this way we will be able to reach the people who we really need to reach.
Very good, thank you. And I think we can move to the next question, which was more on swallowing. How, can we go to the next slide, please? Which was more on swallowing and what are the unmet needs regarding assessments and the outcomes of swallowing in SMA, and how can address some of this. I think this morning, Kathleen and others addressed already how the scenario of assessments has changed, but maybe we want to expand a bit more on that, also in terms of unmet needs. Where would you see the priority at the moment in the community in increasing awareness of the need for video fluoroscopy and increasing the number of centers who can perform video fluoroscopy reliably? I mean, I was a bit concerned this morning to hear about how this is very much, video fluoroscopy works better or at its best when it's in the right hands with the right technique, number of frames, and so on. And do you think that one of the next steps should be to promote some training and some awareness and some training in video fluoroscopy, providing some guidelines on what is needed as a minimum for a center and so on?
About sort of working like this stroke centers that they have throughout the United States, and I know other countries, where you can telehealth into a place that has somebody who has specialty training in this to help gain insight. And so I know we've been doing that. I think licensing is just the big thing, but I think the unfortunate fact of the matter is there are not a ton of speech pathologists that are available in this area. And while we can do training to help make more available, the field is still just needing to grow. So I think potentially making like centers of excellence where you can telehealth in and gain that expertise is a great option, because with the technology of fluoroscopy, you can now have somebody telehealth in and dictate real time what's going on and make recommendations and help. So I think that's one way that is a possibility. But at a minimum, setting up extra training. I think, where my mind is really going lately as seeing patients is my biggest question as far as how we can improve quality of life from my perception would be is in patients who have profound deficits to the point where they're G-tube dependent, typically requiring suctioning, and maybe they're taking tastes, but really minimal oral intake. Is there, how much room do we have for improvement if we do rehabilitation? And I think that's really the big question that seems to be unknown at this point. And I think we need to answer first, because that's a huge population of patients that we have that have profound deficits. Their x-rays are showing that there is some cranial nerve intact that's making some swallowing facility. Now it's very impaired, but we still see some movement, which to me says there is some potential that we can kind of build on that and establish new neural networks if targeted in the right way, or at least reason enough to try. But I don't think anyone has systematically looked at the rehabilitation part, which is really, I think, really, really important moving forward.
Now, my next question is to you, but also to the others. We have some relatively recent standards of care that were published in 2018, but this was before the new therapies arrived. This morning, I showed very briefly the scheme saying in infantile onset, all children should have video fluoroscopy at the beginning and so on. You or the others think that all this, the way this was structured still holds true. We have sort of addressed this morning already in our presentations, but probably it's better to also to hear from the family representatives and from the others. Do we think we know enough that we could modify the standards of care, or we are still in a learning phase where we are collecting evidence to see how things could be done differently when we know a bit more? Because, I don't want to give my opinion. I want to hear from the others.
I'm curious what the others think. I would say probably what counterintuitive to what you would think I would say is that I think that these routine assessments are still really important. We don't know enough at all about, what matters, what doesn't, what influences these outcomes. I actually would advise that they are modified in the direction of not saying that only SMA type 1s should get a swallow study. I think that beyond that should also, or some type of instrumental assessment, not just based on symptoms, because of what I said is these patients typically, if there are profound deficits, they haven't had symptoms. So I think that, to me, as far as my practice, regardless of type, I'll do a baseline assessment so that I know what I'm working with if patient symptoms come up, and so we can see if things progress. I'm curious what others think, though.
I would like to hear the family perspective, or we have a few people on the line who have a more direct experience of how daunting these assessments are when they are performed on them. Do you think we are doing too much at the moment? Do you think, would you agree with Kathleen that we still need to do all the assessments as we used to do before the therapist?
I can perhaps start. It's probably an annoying answer, but I think now with these treatments, we have even more differences between individuals. So I think what is actually really important here is that we make these decisions not based on SMA type or on whatever, but really look at the individual patient and see what the patient needs, where is the person coming from, where is he or she going, and make these decisions based on that. Not only, I think, what we see clinically, but also what are the expectations of the patients, what are the needs of the patients, what is important for a specific patient, and based on that decides how often or what to assess. I know it's not a black and white answer, but
I don't know. I think this is the right answer if you are treated, if you are followed in a center where the people who are in charge are aware of the standards of care and are able to make a decision. But the reason why we provide guidelines is that we provide guidelines for centers where there is less expertise and there is some need for some guidance, and the guidance have to come in cluster. We may change type. Actually, in the last standards of care, we had already switched from types to functional status. We were talking about non-sitters, sitters, and walkers. So what you're saying is understandable and is right. But on the other hand, we have to provide some guidelines using some suggestions where, we cannot just provide general guidelines. People will need to orientate on what to do with a non-sitter who may be more severe, with a sitter, and so on. So what you say is right, but it has to take into account the other side of this.
I know, I agree, and I completely actually agree with that. And I think we also, again, as a community, every one of us need to invest more also in education, in educating on standards of care. I think this is super important. Yeah.
And Eugenio, if I may also say, I don't think, regarding your question, I am not a family, of course, and I'm not a patient, but I think that we still need to, personally, that's my opinion, I think we need to collect more information before we can think of future directions and recommendations.
And I completely agree, but I wanted to hear from others as well. So I think
Eugenia, would you allow me just one short comment? Because I agree with everything that's been said, but I was struck by let's say the availability, or maybe even a reimbursement issue when it comes to this type of studies. I think more in general, it would be very helpful to have some sort of mention in future standards of care that this is an important topic, because otherwise we might run into the issue that we want to do the studies, but that they are not reimbursed and that we are more or less running in circles.
No, you are absolutely right. This is why we are taking some time to think, because there is a lot of pressure in providing new standards of care guidelines following the new disease-modifying therapies. And this is why we are taking some time, because I think we still have to collect experience on what has changed, what are the unmet needs. So for the time being, I would be more keen on producing a document on which are the unmet needs that we have to address and stimulating people to collect as much information, because I don't think we are ready to have a consensus on how to change our care. I don't think we know enough. I think we all agree on this, that we are still in between territory. We just started with the new disease model. We don't have long follow-up to be sure of what is the efficacy of what we are doing.
Can I briefly,
Can I just comment also? For me as an adult that don't have any swallowing problem, but are in the risk of getting in the future, in the standard of care, is there any preventing treatment for getting swallowing problem? Because as I understand, it's more focusing on patients who have this problem and then get treated, but not so much in preventing it. I haven't experienced it anyway. I just get the question if I experience any problem with the swallowing, and I answer no, and then it's we don't do anything more about that, but to prevent it.
Yeah, that's a very fair point. Now, I'm very happy that this session had a lot of discussion, but I'm told that we are close to the end of the meeting, so I will hand over to Ksenia and to Nicole for the final part.
Thank you everyone for joining this event, and also our expert for their contribution. I think it was really an amazing event. Also, it's quite clear to me that this is only one step in our journey and that we need to further elaborate on this topic. There is so many unmet needs, there is so many unanswered questions for which we as a collaborative community need to find solutions. And we see from today that there are actually already quite some people working on this topic in this area, people who are very dedicated, who are passionate and have a huge experience and knowledge. And for me, it's really now of key importance that we draw together all these little bits and pieces that are around, and that we really start understanding also as a community what is happening already in the field, but not only what's published or publishable, but also like really understand who is collecting actually which piece of data out there, and also find ways how we can merge that data together, for example, in a fair metadata repository on nutrition, who knows. And second is really to bring people together in events like this one, so that they can share experience, share knowledge, and also potentially start collaborations. And also it's important from all the stakeholders to be supportive and to find ways how we can really bring the solutions eventually also to patients. And this is really also where I personally see the role of a patient organization umbrella such as SMA Europe. I think SMA Europe can be the platform, or can be used as the platform to facilitate exchange, to foster collaboration, but also to be supportive in finding support to eventually bring solution to the patient community. Because I think that's what we are all striving for, and that's what we want to achieve.
So I'm really looking very, very much forward to be on this journey together with you. And as we from SMA Europe would want to say, all together, one goal. And with that, I'm handing over to Xenia.
Thank you very much, Nicole. And thank also for the insightful comments. I think that we can all agree about that. It stands up for me, the collaborative and the collaboration word here. I think we cannot do it as a single effort. And I can bring from our side that as industry representative, we are happy to be part of this collaboration and to support the work that needs to go into that. And we see that's a lot of open questions. So I think it's been a workshop that full of information, full of insights. And so before closing, I really need to thank a number of people. I need to thank our speakers, the one in person, the one virtual, and some of them joined and dialed in the middle of the night. So extra kudos for that. To thank, of course, my co-host. That has been great, and all the people that made possible this organization, and also the audience, which not only dialed in, but also was very engaged in providing questions, and we hope also potential call for collaboration in the future. And so we hope you enjoyed the event, and that this will be just the beginning of a journey. And with having said that, I really, really wish you a nice rest of the days. And stay tuned. Let's see what else will bring this journey. Thank you.